So the main point of this video, and I'll hope that my clicker starts working, otherwise I'll be tied to my laptop, is, we change the types of data we look at, we change the way we interact with the healthcare system, right? Where it used to be all in an inpatient setting or at a doctor's office, now that's not happening anymore. It's actually interesting, before, like 2 weeks ago, I took my son to a pediatrician's appointment, and the pediatrician looked at the chart and said, hey, I see he got COVID vaccinated. He's 2 years old. Where did you get that done? They didn't know. I'm like, well, CVS has a minute clinic. It's right down from my house. I didn't have to drive 45 minutes in pre-pandemic type traffic to go to the pediatrician anymore. When one of my kids has a diaper rash, I can do that via telehealth now. It's a little awkward, if you can imagine, holding the phone, but you get used to it to avoid the half day being wasted. So it's quite different. However, there's still some problems. So I think that the silver lining of the pandemic is that some of that stuff has changed. Some of those technologies have advanced quite nicely over the past couple of years, right? So there's 320 million wearable devices being shipped this year alone. And I don't know how you use that stuff, but my running coach sees my blood pressure, and my heart rate and everything that I'm doing while I'm exercising. It would be nice if my doctor could see that too. I don't want to overwhelm them, but it would be nice. But on the other hand, there's still issues like, I don't know about you guys, but catching up on those waiting lists is awful. We just don't know how to do that. My daughter had an ophthalmology appointment that took me 6 months to get, and then she coughed, and we pushed her out for another 9 months. She had a negative COVID test too, mind you, but because she was coughing, this Saturday, I hope it's happening. Now, in comparison, let me tell you something. We've heard about consumer engagement a lot over the past couple of days. I took my kids to Disney last week. What an experience. I don't know if you've ever been. Disney has always been good at customer service, but I hadn't been in a couple of years, and last week was just amazing. I mean, I had my Magic Band, I had my app on the phone. I didn't need to talk to anyone. I didn't need to check into the hotel. I didn't need to pull a single credit card. I swiped everything. The app laid out an itinerary based on analytics that it did on everyone's data, what would be the predicted wait times for each ride, and my personal preferences, right? So it sent me from the Death Star to Peter Pan to the Haunted Mansion to Mickey Mouse, catch the fireworks. My kids passed out at 10:31 p.m. Parenting of the Year award here, and then we lived happily ever after. It was amazing. I work in this industry, and I'm always scared to share data. I think we talked about ethics earlier. So a couple of years ago, I was asked to share my medical record with the state of Massachusetts. And can you believe it? I said no, because it just made me uncomfortable. My real excuse is it's not InterSystems technology that the state is using, but it just made me uncomfortable and unfamiliar with what we do in this industry, right? So what do you think other people feel like? There's definitely an education component, how are you going to use this data? Is it going to be anonymized? What type of analytics are you going to do? For what purpose? So there's work we have to do. But if we can do that, take all that data, kind of bring it together, with all these new participants in the ecosystem that we saw, so pharmacies, maybe employment data, government data, social determinants of health, harmonize that data into a record that we can then kind of democratize, and sure enough, patients will have to consent or agree to what type of information to share for this, but then make that available to analytics, research, innovation. We can achieve a lot in terms of what we can do with that data. I want to talk a little bit about what that looks like on the product side, and then I'll get into some use cases. But so, most of you kind of have this foundation in the middle already in some shape or another, right? We just need to extend that and then use it as a pipeline for analytics, those records and that information that you've stored already. So what does that pipeline look like? And I know the display here is a little difficult if you're sitting in the back, but I'll talk you through this. So the idea is on the left, you have all the different data sources that I just talked about, and you send that data through kind of this analytics pipeline, right? Where we aggregate, we deduplicate, we normalize, we harmonize it into, the longitudinal records for each individual patient, and then we make that available as a service to users, to analytics, to external tool sets. I'll talk about our tools in a little bit. But we make it available to, dashboards, Power BI, machine learning algorithms, and then ideally we operationalize whatever insights we get back from that into the physician workflow or back to the patient as the consumer. That would be great. I thought about this, so I said no to sharing my record, and I thought about why was I so happy to share all my information at Disney, right? Because I didn't care. They could have put a patch on my kid to predict when they would get hungry, so I could order some fries that would magically appear before there's an epic meltdown, and I would have been happy, right? So my immediate benefit and me understanding what the data is being used for, this story did not make me sound good. But if I understand what that data is being used for, great. And if I can get some feedback from the insights we're garnering that help me personally either live a better life, have me be healthier, save me time not having to go to the doctor, then I'm all for it. So it's not just technology. I actually think the technology is the easy part, but there's that aspect of it that's more complicated. Now, one of the systems, and you've heard about this sometime this morning too, one of the systems that's providing very, very rich data on these patients is TrackCare, obviously. So if you haven't looked at the innovation toolkit, to take a look at that. That's certainly a very product-specific way of getting all of that data out of TrackCare and making that available through FHIR to, any of these innovative technologies like ML, and I have a personal passion for ML. I'll talk about that a little bit. Or to a Smart on FHIR app or whatever other application or API that might be. Right? So this is a long list. I tried to bold because I was aware the last 2 days that the setup is hard to read in the back. So hopefully the ugly font will somehow translate. And I'm not going to go through all of these in detail, but everything we do kind of centers around our data model. We've actually seen a shift in how analytics is being used over the last couple of years. Like when we first sold HealthShare Tracker or something, analytics was always the end goal, right? That was the holy grail you wanted to get to. You do your operational stuff first, and then eventually you can use that same data for analytics. Now what we're seeing more and more is customers putting in analytics as one of the first things to look at data quality, for example. Right? Because if you can get an overarching view of that data immediately and kind of analyze what it looks like, what came from where, what code sets are being used, who's maybe not sending specific things, so data completeness, that's a different type of analytics that you can do early on. But everything, all the tools we provide of doing analytics one way or the other kind of center around the patient-centric record, right? And then you have medications, encounters, labs, everything that belongs to that patient social determinants that you can analyze based on that. So, and I'll talk about how customers are using some of these tools, but obviously we have data management tools in the back, we have our own visualization tools, and very seamless tight integration with external tools like Power BI or Tableau was what Carmen showed earlier. But then analytics goes beyond that, right? We see a lot of customers doing notifications based on either specific events or on cohorts of patients. So I heard on Monday, I was part of the user group here, and I heard this concept of the virtual ward, which is a perfect example of building a dynamic cohort, right? You build a cohort of your COPD patients that are being treated at home, and then some discharge code comes in and the patient falls off of the cohort. But while they're in this cohort or this virtual ward, you can, look at that list of patients, do something with it, or send notifications based on changes of that ward. So that's a perfect use case. And you saw some of these other tools like the Action Engine and low-no code. If you have FHIR repositories, you can build analytics based on a SQL representation of that data. We now have the anonymizer that makes it a little easier to convince people to make that data available for either analytics or research, because there's always that kind of, I don't want to use this data for anything but at the care setting. So how do our customers use analytics? There's a lot of variety of ways. So I mentioned data quality, then there's the operational piece, and then there's a lot of the clinical population health, metrics, performance, benchmarking of different facilities or providers. But those are all examples. So at the simplest case, you could look at how busy is how's my system being utilized? Like if you're having an HIE, how many people are logging in? How many different data types am I getting a month? How many notifications am I sending out? Simple things like that. And then reports on bed utilization, ambulance response times. I think that's one of the ones that we work with one customer. And then you can go to individual care. So what's a patient overdue? What hasn't happened? Have they no-showed for an appointment? Do they have these three conditions or filters fulfilled? And then a new diagnosis comes in that puts them on a specific list. Duplicative testing. So you could look at any of these. I don't want to go through this in detail, but there's a lot of varieties of analytics that you could do. So let me talk to you about a couple of customer examples. I'll do the 2 US ones first. HealthX, and you can probably not read all these numbers, so you'll have to believe me that they're pretty impressive. But HealthX is one of the public HIEs in the US in the Long Island, New York City area. Their official patient count ranges, these numbers are from 2020, so they're a little out of date. They're somewhere in the mid 20 million patients right now, unique patients that is, that they have in the system. A wide variety of data types, lots of systems connected, from pharmacies to hospitals, to ACOs, insurance providers, or health plans as we call them. They're one of their first use cases to get quickly get kind of value out of the system was notifications. But this next slide kind of shows that it'll be impossible to read. But basically, they have 3 pillars of how they provide value. The first one was notifications, or data delivery, right? So send me an alert when someone gets admitted to the ED, and then send me an alert again when they get discharged with a copy of the discharge summary. And then they do more complicated alerts that look at predictive scores, and I'll talk about that in a second. Then they focused on data retrieval, so getting a complete record back. And then third, they went to analytics. Now, a lot of the analytics that they do is for public health reporting purposes. But as I just mentioned, they do these ML predictions on a variety of things like ED readmission risks, risk of getting a non-communicable disease, and then they fire off notifications based on those, right? So I don't know how many those are, but there's probably like 20 different things that they notify on for ML risk scores. And they then embed that directly into their version of the viewer. So what you'll see here in red is those are kind of the elevated scores. So this patient has a high probability of being readmitted, and they have a high probability of getting diabetes in the next, I don't remember what the time frame is, next year or next 3 years. But that's how they do it. So they obviously have a vast or a huge data set that they're running this on. The second customer that I want to talk about is actually also in New York. I don't know why New York is always on the forefront, but this is Northwell Health. They're, I can't remember, the 3rd largest employer in the state. They built a unified care record. They have actually a high development staff that built their own care management tool, which is what they call Care Tool. So they pull the records out of like our HealthShare solution, and then they put risk scores next to that. Most of those are not ML based. They, for example, look at readmissions based on an algorithm called LACE, where you look at 4 different factors: length of stay, acuity, comorbidities, and then number of emergency admissions in the last, I don't know how many days. But they used that tool quite extensively. They sent a lot of notifications. And what they discovered was, speaking of patient engagement, for example, what they do is they found out that they're providing these free services. So if patients need a nurse or they need a health coach or a nutritionist, they provide that for free. But they'll cold call you and say, hey, do you want to work with a nutritionist? And they got anywhere from 10 to 20% engagement rates, which is not great. But what they found was that when the patient's in the hospital and has a bunch of conditions that are met, and they fire off an alert to someone right then and deploy the staff into their facility, the engagement rate goes up to 85%, right? Because now the patient is scared, they're seeing someone in person. So they're using analytics a lot like that. They're a huge Microsoft shop, so a lot of the analytics they do is self-service through Power BI. But then they're attempting to dip their toes into the machine learning world. So one of the projects we did with them was looking at length of stay and what they call excess days. So what happens for them is each time a patient gets admitted, there's a CMS is one of the federal agencies, and there's a CMS DRG-based prediction of how long that patient is going to stay in the hospital. Now, if the patient stays any longer for each day, they're being charged, right? And they're not being reimbursed for that. So they're saying that algorithm, basing it on the CMS prediction, costs them about $10 million a hospital a year, and they have about 23 hospitals. So they said, if you can help us with this problem with maybe machine learning, that'd be a good one. We looked at how accurate that CMS prediction is, and it's only about 35% accurate. The thing that you see there on the right, that quadrant, that's a confusion matrix that basically say how, did you guess that the patient was going to be discharged today, and did he get discharged? Or did you guess he was going to be discharged, he didn't get discharged? So the circled area are the ones where where that algorithm guessed right, and that's only 35%. The way they wanted to do it was, let's see if ML can get a higher score, and then let's embed that score into our rounding application that's Teams-based on the phone. So basically, their clinical staff uses that when they do their rounds at 9 a.m. and 2 p.m. And if they could see a score, how likely is it that this patient is going to be discharged today, they can act accordingly. So then what we did for machine learning is we took the last 4 years of data, inpatient data, and we only used 6 of the around 50 tables that we have in our products. So encounters, patients, orders, meds, documents, and observations. But they have so much data in these, it's almost 1 billion rows. And then each table has about 20, 25 columns. So we were looking about 22 billion raw data points before kind of doing data engineering and exploding out the fields for ML. So what we did for ML is, add basically virtual additional columns that look at duration based on 2 sets of dates, or vectorizing text, or categorizing, one-hot encoding categories, stuff like that. So it's a lot of data that they had. We did get a model that had about an 84% accuracy. Now accuracy, so for the ML geeks, the AUC was about 90%. Let me explain this a little bit in layman terms. You can get a pretty good model on accuracy for things that have kind of a binary thing, right? Let's say you have 100 patients and one of them has cancer. How do you get the most accurate model without doing any work? You predict nobody has cancer, because then you have a 99% accuracy. So, you could kind of, the accuracy score can be a little deceiving when it's a model that's based on something like that. So the area under the curve kind of looks and offsets like how many positives and how many negatives, and how often is the positive has a higher probability than the negative. And it calculates it based on that. And 90% is pretty good. We also spend a lot of time on explainability. So showing them the features that influence whether someone is going to be discharged. For example, they like getting people out of the hospital on Fridays. Time of day makes a difference. If it's already 4 p.m., they're probably not being discharged anymore, even with all the paperwork you have to go through. How long have they been there before? All those things had a pretty significant impact. And what you see on the lower right, and I'll be happy to share these slides with anyone, is the explainability that we can display within the app. So as they're looking at a particular patient, this one had a probability of about 13% of being discharged. Why was that probability only 13%? And we told them exactly why. It was like a Sunday, it was already 2 p.m., so that they, for each patient, can kind of figure out, well, why was the score that way? Believe it or not, we're still working on this. So we're now adding additional tables to it to see if we can get the model even better. The last example I want to talk about is international. So this is MediClinic. They actually are a customer in a couple different countries of ours. But the one that we did a proof of concept with on analytics is the one in South Africa. So they're a HealthShare customer, and they had problems with their existing data warehousing strategy. But they really wanted to look at a couple of clinical use cases. And I didn't include screenshots here because it was just a POC, but they actually did it all within our technology. But they looked at diabetes prediction, high utilizers in the emergency department, and early warning scores for sepsis. Now, none of these were done with machine learning. These are just algorithms, but based on the analytics data set that we had for them. They're nowhere near as big as the two customers that I mentioned before, but they were pretty happy with the outcome. So we're moving forward to see how we productize that now or get it into production for them. And with that, I'll leave it to Mike to close with a visionary statement or some questions.